Good evening, friends. Now you are watching Surgical Educator RKT. Today we are discussing about a very important surgical problem called pseudocyst of pancreas. Why it is called pseudocyst? Because every cyst has a epithelial lining. The cardinal feature of any cyst, every cyst has a epithelial lining. But in case of pseudocyst, it is not lined by epithelium. Wall of the pseudocyst made up of granulation tissue or fibrosis. So it is called pseudocyst. What is the etiology of? What is the cause of pseudocyst? It is a complication of acute pancreatitis or chronic pancreatitis or any blunt trauma or penetrating trauma to pancreas. As a complication of acute pancreatitis, there is a pancreatic fluid collection. Normally, 40 to 50% of cases, it is resolved spontaneously within a 4 to 5 week. But if fluid not resolved, pancreatic fluid collection is not resolved, and if pancreatic fluid collection not spontaneously resolved in 4 to 5 weeks, and time required for the formation of pseudocyst is around 4 weeks. If pseudocysts remain after 6 weeks and size more than 6 centimeter, it requires surgical intervention. Important point, always remember 4 6 6, 4 week time required for the formation of the pseudocyst. If size of the pseudocyst more than 6 centimeter and remain unresolved after the 6 week, only then surgical intervention required, because is a very difficult to treat if complication occur. So we have to deal with it timely. Which location? Most common location of the pseudocyst of pancreas is lesser sac, in between stomach, a space in between posterior part of the posterior wall of the stomach and pancreas, because pancreas act as a cushion over stomach. Mostly fluid collected in a lesser sac in case of complication of acute pancreatitis. Now, what are the clinical features? Clinical features depending upon size of pseudocyst. If large size, there is a compression system, compression symptom, because it located uh, under the posterior wall of the stomach, so it compress stomach. So there is early satiety, upper abdominal discomfort, a felt lump, and on percussion there is a tympanic node over the lump, because normally cyst is the fluid field, but in front of cyst there is a gas filled stomach, so we can elicit tympanic node over the lump. And important of the lump cannot be moved vertically, we can move horizontally. And most important thing, we all knows pancreas is a retroperitoneal organ, so these lumps not moved with respiration. There are some other lump present in the epigastrium region. That is a differential diagnosis for the pseudocyst. First, CA stomach, gastrointestinal stromal tumor of stomach. In case of hepatomegaly, when left lobe involved more than right lobe. And very important thing is AAA, abdominal aortic aneurysm. Abdominal aortic aneurysm. In aneurysm, we feel pulsation. Pulsation are expansile in nature. We can also see the pulsation, elicit the pulsation. We can feel the pulsation over the pseudocyst, but pulsation of the pseudocysts are transmitted because cysts lie over the aorta and pulsation of aorta transmitted through the cyst wall to the upper abdomen. So we can differentiate between aortic aneurysm or this. Other clinical features: if pseudocyst of pancreas compress over the biliary system, extra hepatic biliary system, CBD, right hepatic duct, so chances of obstructed jaundice like pale yellow skin and pale yellow sclera is present, loss of appetite, nausea and vomiting off and on. How we how will we investigate? Ultrasound and contrast enhanced tomography. CECT is the gold standard for the location and extent of the cyst. And MRCP is also considered for the diagnosis of the pseudopancreatic cyst because MRCP can diagnose ductal system of biliary tract as well as the pancreatic ductal system very efficiently. Other investigation is the EUS, endoscopic ultrasound, because it clearly seen the fluid and loculi in the cyst, septa in the cyst, and other solid structure which can be differentiate pseudocyst of the pancreas with mucinous cyst adenoma. So endoscopic ultrasound is the most sensitive investigation. How can we differentiate between mucinous cyst adenoma and pseudocyst of the pancreas? By the fluid analysis, we aspirate percutaneously transhepatic aspiration of cystic fluid. If cystic fluid rich in amylase activity and low in CA activity, carcinogenic embryonic antigen. High amylase, low CA means pseudocyst. High CA, low amylase means mucinous cyst adenoma, which is malignant potential. What is the complication of the pseudocyst? Sometimes pseudocyst rupture in the pleural cavity causing ascites. Sometimes it is rupture into pleural cavity causing pleural effusion, and sometimes due to pressure effect it eroded artery because pancreatic enzyme has a elastase which directly act upon the blood vessels, elastin fiber of the blood vessels, causing hematemesis and melena. So if pseudocyst of pancreas not dissolved within 6 weeks, we have to step to manage it: surgical management or endoscopic management. Surgical management is operation is called cystogastroscopy. There is a stomach. This is the pancreas. In between there is cyst. So we open the anterior wall of the stomach, and by the syringe we aspirate the cystic fluid through the posterior abdominal wall and make a hole. So all the fluid internally drainage through stomach and GIT. Nowadays endoscopic endoscopic gastrocystostomy done, in which there is a communication between cyst and stomach is made, and a placement of the stent, so fluid drained through stomach. If cyst is close to duodenum, so endoscopically we can perform endoscopic duodenocystostomy. That's all. Thank you.